its health future by design, not by default, building on the work done by others and in other places.
Magda, Your Excellencies, our former heads of states, Baba, former President Olusegun Obasanjo, our mother, former President Salif Johnson, former President Amina Fakim, my colleagues, Honorable, consider new multilateral arrangements. As we all call for a new global health order. I draw on some of the work that we have done over the last several years in the Future of Health and Economic Resiliency Commission, which I had the privilege of co-chairing with Minister Awakol Seck of Senegal and many colleagues from all over the continent who have been thinking about this effort, including the Rockefeller Foundation. That this summit is holding in Accra, Ghana, is quite fitting. For Ghana, as the President said, is the birthplace of Pan-Africanism, and we are being hosted also by a fitting successor to the father of Pan-Africanism, the late President Kwame Nkrumah. And we appreciate His Excellency President John Dramani Mahama, President and Commander-in-Chief of the Republic of Ghana, for his incredible leadership in convening this effort. With this convening, we are continuing the journey of our forebearers, whose vision, courage, and sacrifices must not be left to languish. Clearly, declining traditional donor interest in global health has precipitated the need to rethink global governance and the whole global ecosystem, like Magda shared with us. This, after appreciating the tremendous financial and technical support to poorer countries from the people and governments of the wealthier nations, the United States, Europe, United Kingdom, and several others. This has contributed to significant reductions in child mortality, expanded access to life-saving interventions, reversed key infectious diseases like HIV, TB, and malaria. Thank you, President Obasanjo. Expanded access to immunization, and now almost on the verge of polio eradication. Yet, half the world's population still have no access to basic health care. Endemic diseases, rising antimicrobial resistance, new and re-emerging diseases, non-communicable diseases, and several other problems are raising significant challenges that no longer have obvious answers. Global health, until recently, represents around almost 40-50 billion or more US dollars annually in official development assistance for health. And commonly, global health is described with reference to only a few issues, including diseases like HIV, malaria, TB, or with references to processes or focus areas, include health financing, human resources for health, or maternal and child health. Most of how we address these issues have been influenced by limited perspectives. The lens of others, our perspectives, African perspectives, contributions, especially in the poorer countries, have been much less acknowledged or made relevant. For example, much of the progress in advancing health outcomes in lower income countries and low middle income countries in the last 25 years were driven by domestic financing and domestic actors in poor countries, of course with the support of our external partners. Now, as we're seeing major global shifts, the geopolitical shift and the nationalistic politics that is disrupting global health, these shifts provide us with a natural opportunity to assess what we have and to chart a much better future ahead, one that respects each country and continent's sovereignty and self-determination. The truth is that we cannot expect to build a healthier population purely on the back of other nations' money or generosity, or without connecting global with our local needs. There's no doubt that some of the stated goals of global health are positive and expansive. Yet, we also know that there are several imperfections and course corrections are necessary. And to chart a way forward, we need to understand the legacies upon which the global health system was built. One that is clearly positive and another one that is less so. The positive legacy evolved in response to the 19th century pandemics spread by globalization of commercial and military activities that led to a series of sanitary conferences at which countries agreed to collaborate in the fight against infectious diseases, working together. The reasons for such collaborations have endured, essentially unchanged for the last 200 years. First, the many ties between nations create collective health risks that are difficult to manage independently. And secondly, sharing knowledge and experience accelerates learning and facilitates rapid progress. Thirdly, agreeing on rules and standards supports the comparability of information, helps establish good practices, and underpins shared understanding and mutual trust. All these reasons drive the need for our nations to collaborate. And in the last 25 years, especially the golden era of global health, these collaborations have contributed to some of the progress that we have seen. On the less positive side of the legacy of global health, the direct ancestor of global health is tropical medicine, a field that grew directly out of colonialism and similar imperial activities, which we have to acknowledge. And the continuity between that colonial period and the immediate post-colonial period was so obvious that the Honorable Kwame Nkrumah needed only a few years to coin the term and write a book about it, Neo-Colonialism, the last stage of imperialism. President Nkrumah laid particular emphasis on the economic extraction that continued and the trade imbalances and regulation that limited Ghana's choices at that time. This fact that unfair economic relationships are critical obstacles to public health has not escaped others, and many have tried in vain to address it. There were arguments that colonial trade relationships were structurally incapable of producing development and would only increase dependency by the colonies on the metropoles. Now, long before now, 70 years ago at the Bandung Conference, when the non-aligned movement was created, our countries organized to advance their collective interest. In the 70s, WHO articulated the same point in the Alma Ata Declaration by calling for a new international order, similar to what we are calling now, emphasizing global cooperation to achieve health for all. In the 90s, following intense pressure from activists, the Heavily Indebted Poor Countries Initiative was launched by the International Monetary Fund and the World Bank to address unsustainable indebtedness as another attempt to manage the sequelae of structural inequalities in the world economy. In the 2000s, the Commission on Macroeconomics and Health reached the same conclusion, calling for a new global partnership between the developed and developing countries. But despite a conclusion made severally, repeatedly over the better part of a century, most of the institutions in global health and development have not really focused significantly on the needed reforms. For global health, the consequence of these macroeconomic and trade issues is a policy space that has been constrained by several items in several ways. First, the secondary status of global health to commercial and national strategic interest discourages engagement with some of the most significant influences on health. Secondly, with the partial exception of tobacco control, global health advocates had been unable to shape the trade in commercial products. Health advocates seeking either to advance positive possibilities, such as intellectual property rights that go beyond the TRIPS agreement for patents, trademarks, and copyrights, or even limit those with harmful potential, such as ultra-processed foods, sugar-sweetened beverages, tobacco and others, have often been unsuccessful, and I am glad that Tedros highlighted that in his remarks. Third, the dependence on donor financing and their interest meant that research and project funding was focused on ever-changing priorities of specialists and advocates in the donor countries rather than responding to the real felt needs in the receiving countries. By earmarking contributions to WHO, for instance, the same donors have undermined WHO's independence, and Dr. Tedros is basically going through that. Funding priorities were set by donor nations, reducing the agency of recipient countries and limiting even WHO's independence. Plus, the resultant deindustrialization or lack of manufacturing capacity prevalent in our countries by channeling organized demands away from our local markets. And fourthly, the dominance of those macroeconomic factors enforces an intellectual ecology in which economic factors have primacy. This is seen in the high emphasis on value for money. Value for money brings a focus that challenges public priorities that do not generate easily measured economic gains, such as services for the poor, improving health systems, or even the basics like water and hygiene. In place of public health staples common to all rich countries, sanitation, hygiene, water filtration, public utilities, nutrition, housing, waste removal and management, inspection and enforcement, and the like, global health had emphasized more of other things and tools. Important issues like malaria, TB, HIV, and other specific diseases that also have, by chance, strong lobbyists, drug companies, advocates, academic specialists, and other philanthropists. The primarily disease focus does not necessarily always underlie our own ideas of health or well-being, but it does match the professional and economic interests that tend to thrive in the global health arena in some instances. These limitations are similarly evident in the global health, academic, and private sector partnerships. However, despite these limitations, we have seen some progress in the last 25 years. I had mentioned the Global Fund as a good example, the Gavi, the Vaccine Alliance, the Global Financing Facility, CEPI, Pandemic Fund, and several others. More than 70 global health partnerships. Meanwhile, now the resources are dwindling. Fragmentation has become even more of a challenge. So with this background, where do we go from here after this landmark summit? I propose a few ideas specific for African leaders and the Friends of Africa to consider towards reasserting health sovereignty for the African continent and similar other areas. I will itemize them. First, for us to think about establishing an Africa, Asia, Latin America, and the Caribbean Strategic Alliance. Considering the long-term strategic alliances which had been forged for the last 70 years or more, since the Bandung conferences, forerunners to the latter Alma Ata Declaration that birthed primary health care in 1978, African continental leadership should extend its hands to willing similar countries in other regions to form an axis for reshaping the global governance arrangements and the agenda of global health. This needs care so that we don't fall into big power politics. But it is necessary if the idea of regional sovereignty is to manifest in the face of existing huge power imbalances. Such an alliance can mandate appropriate expertise to renegotiate trade terms, including for health products, consider restorative measures for past unresolved injustices. 2, rebalance the paradigms of the cult of panacea, the things and tools, with the cult of hygiene, prevention, from disease management to health production, prevention and wellness. At the country level, ensure that investment cases are owned by national governments in partnership with our civil society and the private sector, so that recurrent cost implications of externally determined investments are accounted beforehand, and that no supranational interest subvert our national sovereignty. Third, to focus on African data sovereignty. Relevant national and continental institutions should immediately come together to assess, coordinate how Africa standardizes, regulates and controls, protects and develops its health data infrastructure, and limit its opportunities for extraction or exploitation by outside interest. For example, creating a charter on Africa health data. Fourth, to put our pocket where our mouth is, and His Excellency President Mahama said that, Africa cannot afford to outsource its most important health priorities by continued dependency. There is need to pivot towards significant increases in domestic financing mobilization, including push for renegotiated debt relief, innovative tariffs and taxes. Tedros listed them out: airlines, mining, tourism, and develop new domestic financing models. The African Development Bank and Afrexim Bank should be mandated to develop robust financial instruments and deploy them towards enhancing Africa's health. We need to explore private sector investment models and partnerships to complement the public sectors, unlock our value chains, while at the same time protecting the public mission. Fifthly, end the Geneva mission in global health. There should be no need to situate malaria, HIV, tuberculosis, or measles vaccines discussions in faraway expensive capitals that don't have that experience of these diseases. We have enough beautiful land, decent real estate, and good life from Dakar to Accra, to Abuja, to Addis, to Nairobi and Lusaka. Move all global health institutions closer to where the problems are located, whether in Mumbai, Jakarta, or Colombo, while at the same time rationalizing those institutions as they evolve away from delivering products to generating global public goods. Number 6, focus on trade in health and medical industrialization. We need ministers of trade, ministers of finance in this conversation. Develop and use the AfCFTA to accelerate intra-African trade in health commodities and services. The UN Economic Commission for Africa is well positioned to advance the idea of a continental health market with proper regulatory standards, an effective medicines regulatory agency, harmonized human resource professional regulations, facilitating movement of people and things, provide robust incentives for domestic manufacturing of test kits, drugs, biologicals, equipment, services, digital technology, etc., matched by demand-side market-shaping mechanisms, pulling the demand that we know exists in our population. Number 7, to access the state of intellectual property protection regimes in collaboration, resources and networks, and contextual knowledge to drive innovation.
On the health. And what is Nigeria doing in implementing bold health reforms from financing to primary care? What key choices are
so that we invest where we reap the benefit in population health outcomes. In other words, a system that works for the people to improve outcomes, so not a system that works for the system, and backed by increased financial, by limited, of course, resources like many of our countries. And thirdly, to unlock the healthcare value chain, to look at it as a value chain from diagnostics, pharmaceuticals, biological devices, and encourage the private industry to start to manufacture and then to shape the markets, the 230 million Nigerians. There's a demand in there. Organize that demand, pull procurements, market shaping interventions so that we buy from locally those who are able to manufacture, while we buy from others like us, whether it's Brazil, whether it's India or other places, that we buy the things that we need. And then finally, to build the idea of resilience in terms of health security, the core public health function. That requires many facets. That's what this government is doing, because we see health as key driver of human capital. It's a cost as also a consequence, and it's an investment. It's a long journey. We've started. This president is 2 years. We think that if Nigeria continues on that path, the trajectory will be different, because the outcomes that matter, responding to the needs of our citizens, reorienting and governing with the citizens at the center, I think will get us closer to that reality. And also to do that, not in isolation as Nigeria, but we see ourselves in the context of our sub-region, with our brethren here in Ghana and many other countries in the West Africa, but also in the context of the continent of Africa and with our friends globally, because it's not Africa in isolation. So we're seeing Nigeria not just going on its own, but that what we do, what we co-create, is in the context of global solidarity, regional solidarity, and also our own neighborhood.
In your keynote, you touched on something which is on the mind of many leaders and, of course, many countries across the continent. You've spoken about African data sovereignty. We know Nigeria is a powerhouse. Young people, I think 1 in 5 African is Nigerian. And you have a mass of information. How does a country like Nigeria tackle something like this?
I think this is an area where I think there's a lot of work that is needed. The backdrop of extraction, whether it's people, whether it's natural resources, whether it's research outputs, or more recently now in the context, we also take into account, whether it's research data. Until now, there are lots of research that happens in the continent. But if you look at the publications, a large number of them are really led by folks that are outside the continent. So we are viewed as a place to go and do interesting things, to have your career, to publish, take the...
Sure that the global framework in terms of benefit sharing is also being addressed. Okay. You served in national, continental, and global
and that we need to change. But we can only do that if African leaders. We need to change. But we can only do that if African leaders, like we're seeing President Mahama and many of our presidents now beginning to do, national priorities, because they are backed by money. National priorities, because they are backed by money and expertise that we think is superior to ours. We need to appreciate what we have as well. Focusing on primary healthcare, we are also including so that it's not only the top elites at the capital, but it's a broad-based one, and see how we can meet some of those needs, which were unanticipated.
Depend also on capacity. I've seen over the past few years how there has been an erosion and, of course, loss of the human capital on the continent. And this, of course, addresses to the private sector, to the public. Depend also on the ideas, it has the talent.
Coordinating Minister of Health and Social Welfare of the Federal Republic of Nigeria. Coordinating Minister of Health and Social Welfare of the Federal Republic of Nigeria for this very insightful conversation. Thank you so much. A round of applause.
Thank you, Magda.
Before I give the floor to Honorable Dan Le Podium, last but not least, Dr.
So without further ado,